A lot of moving parts in everything you've heard described this morning. A little potential for chaos, perhaps, inconsistency across all these different scenarios. Wouldn't surprise us at all. So finding ways to create better systems and better supports is something we always have to think about. Super excited to introduce our next presenter here, CareOregon's own Director of Care Coordination within our population health partnerships. Expect to see some clarity and some really great new ways that we're able to look at our population and frankly just do more good. Please welcome Karissa Smith.
All right, thank you. So like Paul said, I am the Director of Care Coordination here and oversee what we call our regional care teams, which is the teams that we use to provide care coordination. And I'm going to be talking about data and technology today, which is not my strong suit. It is also not what I'm an expert in by any means. I do know care coordination, and I'm going to do my best to talk about data and technology in how we inform that care coordination. But I'm actually a therapist by trade. I've worked in community mental health. I've worked in crisis clinics. I've worked in substance use residential treatment, and then have been sort of in the CCO world for the last 6 years or so. And most of that time in care coordination, I was a care coordinator myself. And then I came to CareOregon about a year and a half ago, and have been in the Population Health Partnerships Department, which is what Paul referenced earlier. So our department, we call it PHP, is not only home of the regional care teams and all of our care coordination activities here at CareOregon, but it's also where we kind of hold our population health strategy. So we have two sides of the house. We have our care coordination side and the pop health side. The pop health side is where we use a lot of the data in trying to implement strategies, and we have several strategies about how to best serve this population across our company and in our provider network in our community as well. Ashley Green's in the back of the room, and she's also in PHP on the pop health side. So when I'm talking about the data, if I say it wrong, she's going to jump up and correct me. Also, if there's questions, I will likely redirect them back to her. And I see several of our own care coordinators in the room, which is awesome, so they can also jump in and offer input as well. So I'm going to bring back Miranda for part of my presentation. You heard Miranda mentioned in several of the presentations today. And what we're going to look at is really how the strategies that we're using to either coordinate care for our members or to proactively identify and outreach to our members, how that actually might impact their day-to-day and their healthcare experience. So for the data side, in care coordination, we kind of have two main ways that we serve our members or that we identify members. So we receive care coordination referrals from maybe several of you in the community, our providers. Care coordination referrals come internally as well from our utilization management team if they identify somebody that might be beneficial of having a care coordinator assigned. Members can call, families can call, etc. But the other way is proactively identifying folks who might be better served in care coordination, and how we identify them is through what we call population segmentation. And this is a tool that basically takes a broad population and separates it into subgroups based on shared experiences or shared demographics. I'm sure most of you have seen on your phone or when you're on social media sites, ads will pop up, and it's a little bit creepy. If you talk about a dog bed, the next day you have ads for dog beds, and it's sort of based on your likes and your interests and your browsing history, your subscriptions to things, etc. The way we use it in healthcare is sort of similar to that, in that we look at the data that we have coming into our systems, like claims. So looking at how people actually utilize the healthcare system. helps us segment population. So why we do this is really to get a better understanding of our population and who we have assigned to us here at CareOregon, the population that we're serving. It also helps us inform resources, how we're going to allocate not only maybe money or different strategies in the community, but also how we allocate our internal resources and our staffing and who we should be looking at and putting more resources towards. Who are those members? We can identify trends within our population, and we're really good at identifying the quote-unquote high utilizers or members who utilize the system a lot. We know who those people are. I think we're all pretty versed in how to serve those members or how to outreach to those members and even who those members are. But when we're looking at that, it's only about, it's less than 1% of our population. So then you got to think about what's the other 99%? Who are they? How do we serve them? Did you have a question?
I was just going to ask, and maybe you'll get to this, but in terms of your algorithms using claims data?
Yes.
There was that article that came out last month about how use of essentially dollars as a proxy for health care needs has a racial bias to it. So I'm just curious if that's been what the discussion has been on your data team about that, and if there are other factors other than claims and costs that might help make up for some of that.
Yeah, Ashley, can you speak to that at all?
Yeah. Actually, the article just got floated around to a bunch of our data analysts also, so that is something that we're looking at. But she'll go into it, but the model is not really necessarily using cost. It's actually looking at the diagnosis and disease burden of a person, which still there could be bias within that. So cost isn't necessarily a variable that's moving people in and out of our segments. It's actually how are they utilizing what resource use are they using? So if someone has diabetes and maybe a mental health condition, they might be grouped together because they're using the same resources. And so it's kind of about, we're using the ACG model, so it's using Johns Hopkins ACG. And she'll kind of go a little bit into it, but the variables that you'll see up there are some examples. So we start with claims, and then ACG has its own outputs that it's looking at around chronic conditions and ED visits and kind of like how is this person experiencing their care and using care versus cost as a proxy. But we actually saw the article, and we're actually going to do a data training around equity in 2020 so we can continue to kind of figure out how we apply those lenses.
Awesome. So glad you're here. So like Ashley was saying, we do use the ACG model, which was developed by Johns Hopkins, as well as looking at our medical claims and our pharmacy claims and how all of that impacts how the member is actually utilizing the healthcare system. The medical claims looks at not only are they going to their PCP or are they quote unquote engaged in their PCP, but are they accessing several different PCPs across the community? Are they accessing behavioral health or specialty services as well as hospital and ED? So the algorithm basically takes all of this information and outputs into a chart over here, and each one of those little dots represents a CareOregon member. And through that, subgroups are identified. And what this model and our really smart people in-house here do is be able to look at those subgroups and kind of add a label to that group based on what they are seeing. So in that process, they came up with 4 different cohorts made up of then 11 segments within all of that work. And we'll be walking through what these segments look like, what the trends are for each segment, as well as potential targeted interventions to be able to utilize for the members of these segments. So the first cohort is the healthy group, and in that group there are 2 segments. So the healthy kids, and these are sort of trends on average that when they looked at that whole group, this is the trends that they were seeing. So that this does not encompass everyone in that group, but these are some of the trends. Where there really wasn't any pattern of condition, they didn't have a lot of healthcare utilization. The average cost, and this is a very average cost, it's per year. But based on that, the intervention that came up was focusing on the wellness and prevention. One thing that this hasn't necessarily taken into account, and I think we might have realized this with the family care transition, was that when we don't have claims on someone coming in, they could, quote unquote, look healthy. And what does that really mean? And is that really accurate? And so there are definite refinements to be done within this algorithm and this in this work. It also could mean that they have been our member, so maybe they're not just new to us and we don't have their claims, but they could have been our member for years and they don't know where to access care, how to access it, or they're just not accessing it in general. And again, that doesn't necessarily mean they're quote unquote healthy. The other side is the healthy adults. On average, 31 years old was the average kind of age of this group. Also had minimal healthcare utilization and also kind of a targeted intervention of looking at wellness and prevention. So then the next cohort was the low-risk group and one segment of acute kids and adults. So this population on average again might have had an acute medical issue but nothing long-term or chronic in nature. We saw that they may go to the ED every once in a while and or the PCP for their acute issue, but really no inpatient stays or long-term chronic illness. And the intervention for this group was really the short-term care coordination, so this might be something that our teams would look at. Also from the clinic side and how the providers and our community network can kind of try to engage this group to make sure that they have what they need. Then the other side of the low risk was the moms and babies. So obviously their cost is higher, as it should be, their delivery and newborn care for that mom and baby. This was also looking at how can the clinic or how can the specialty providers that are already involved with that member and that baby help with the coordination of follow-up care. So then we get into what we call the rising risk cohort. And this is the group that we are trying to focus on in a proactive way. And there are 4 segments within this group. And the first 2 segments are what we call managed. One is chronic managed, the other is complex managed. So on the chronic managed side, we were seeing on average, these members have about 4 chronic conditions. 20% or so had kind of chronic or severe mental health issues, might have a hospital dominant condition, prevalence of conditions like diabetes, hypertension, low back pain, asthma, etc. Also we're seeing that they were engaged with either specialty or primary care in some way. Not significant ED utilization or inpatient, but they were going to see their doctors, to see their specialists. And so this was an area both on both sides where we were looking at how can the clinic who's already engaged with that person either better wrap around that member and make sure that they have what they need. On the other side, for the complex managed, so this was multiple medical conditions, high engagement with PCP or specialists, and again, engagement being defined by claims coming through, meaning that they're accessing their health care in some way. For this group, it was on average 30 or more outpatient visits, very few inpatient or ED. But you can see the difference in cost in that the complex nature of their clinical presentation and symptoms is kind of the driver of that. The intervention that this kind of group strategized and came up with was that the clinic does a review of these patients who are assigned to them, and ensure all their medical issues are being addressed. So then the other two segments of the rising risk category was what we called uncoordinated. This was a similar group, but not as consistent in accessing their primary care specialty provider. So on average, again, this group was found to be mostly in their 30s. They didn't necessarily have chronic conditions, but about 30 or 40% had substance use or tobacco use. On average, they did have some ED utilization, and we found that they were less likely to engage with their PCP. And so this is a group that we within the regional care teams would look at: how do we get involved with these members? How do we outreach to them, make sure they know who their primary care, who they can access, how to navigate the health system. And then on the other side, the chronic uncoordinated had at least 4 chronic conditions, maybe 2 hospital dominant. And on average, I thought this one was interesting, on average they take medication with over 20 ingredients. And that medication piece hasn't come up yet in the other segments. They also had at least 1 unplanned inpatient stay, a couple of ED visits. And again, ensuring that the member is attending their appointments, they know who their providers are, they know who to access and how they can access. And then the last cohort is the high-risk members, and this group has 3 segments. The first one is the high pharmacy. We found that most of the members in this group were likely to have either HIV or rheumatoid arthritis or cancer, which would make sense that they have high-cost medications attached to those conditions. It doesn't necessarily mean that they are high risk. They could be well controlled in nature, or they might have very little symptoms. But the intervention might be a pharmacy med review either at the clinic or here at CareOregon with our pharmacy team. And then the last 2 are the substance use or severe mental illness and chronic mental health conditions, as well as then this extremely complex. This group is who we are used to getting referrals on. We see a lot of these folks in the community. Our care coordinators work with this group a lot. We know them well, you guys know them well. And really working on how can we get them connected with specialty mental health if they need it, more intensive community-based services. They might be homeless and in the community and have barriers to getting to care from transportation. Also, if they just don't have their kind of basic needs met, it's hard to get into your doctor. On the extremely complex side, we jump to, on the medication piece, 51 active ingredients. And this might be a place where we start to look at, is this a Housecall provider member? Is this person better served by that team, or maybe even by the advanced illness care team? Yeah.
What is choice? You put in the previous slide.
Yeah, so choice is it's a contract that's contracted through the state, and it focuses on kind of extra funding and care coordination for members who are at risk of state hospitalization or maybe on civil commitment. In the metro area, each county holds the choice contract.
It's the same as what Aim High used to
Yes,
be.
it used to be called Aim High. For those of you who know Aim High, it's now called Choice. They often capitalize choice, but it's not an acronym for anything, which is interesting. Yep. Yeah, see, it's capitalized, but it doesn't stand for anything. But yes. Is there another question? No? Okay. So in thinking about Miranda and kind of what we just talked about with all of the different segments, does anyone want to take a guess at what group or segment she might fall into? I heard complex managed. Any other thoughts? Yeah, likely complex managed. Again, this rising risk group is also the ones that we were finding we might be able to impact the most through our own care coordination, as well as working with you all to make sure that our members know how to access their care and get care before they would potentially go into a high-risk category. So what do we do with this population? So we were looking at this population and how can we best serve them? What types of interventions do we need to do? And we realized that really the managed, meaning they are accessing healthcare, they are attending appointments, they're seeing their providers, they're maybe seeing specialists, and really that group is quote unquote engaged with their providers. And what we know is that our providers who are engaged with these members, they do really well. They don't necessarily need our teams, and we don't want to duplicate our efforts. We want to make sure that it's a complementary service and partnership between our teams and our network. And so this list is, so this member list can be sent out to the clinics to say, hey, this is the grouping that these members fall into. Are you aware of them? Do you know who they are? Are they engaged with you? We also put these tags or flags into collective or pre-manage. And this is a screenshot of what collective looks like, and this is a member profile. And we push out these flags to the network to show when you search for a member, you can see what segment they fall into. We also have all of our regional care teams or our care coordination teams listed in the care team box. The Abernathy team, we named all of our teams after bridges, and so the Abernathy team works with a lot of the Clackamas County clinics, and so their information is right there. So when you look up this member, you'd be able to see if I do need help or how to access that care team, this is the care team that member belongs to, there's the phone number, etc. Yes?
That presence of the regional care team and collective doesn't necessarily mean they've had any contact with the patient?
Correct.
Ah.
Yes. Yeah, so that is just if all of our members are assigned to a regional care team based on their primary care clinic assignment. And so it doesn't necessarily mean that they have a care coordinator or have ever worked with a care coordinator, but if they need it or if you all were to refer them in, this is the team that member would be assigned to. It's also super helpful from the provider side for our teams. If you all enter who the nurse case manager or whoever, if you guys have care coordinators or some type of case manager at your clinic and that those people are engaged with the member, it's helpful for our teams too to be able to see that info so that we can coordinate better. Has anybody seen this in collective? You have?
You used to have to have an NPI to be in the care teams, but now you don't?
I don't think so anymore. Does anybody know the answer to that? They're starting to put all of the DHS caseworker information in there too. So if a member has an APD, Aging and People with Disabilities caseworker, that information goes in here now with their phone number, which has been super helpful. I don't know that they have NPIs, so I don't know. That's a good question though. So we talked about the managed side, meaning they're engaged with their providers in some way. But the other group is this uncoordinated group who might be utilizing healthcare, but maybe not consistently, or maybe not knowing really who their primary care provider is. And this is the group that we send to our regional care teams, or that we kind of scrub charts and look at who our teams can proactively outreach to and try to engage in care coordination to make sure they know, one, that they have health care or health insurance, that they know who their providers are, they know what benefits they can access and where, etc. So any questions so far before I get into what the care coordination piece is? All right. So our regional care teams are multidisciplinary teams. Again, a few of our care coordinators are here in the audience with us. And we have both clinical and non-clinical care coordinators on our team. So we have our healthcare coordinators who are really kind of that face of the regional care team. They are the ones doing all of the intake. They also are kind of experts on community resources and help with DME. They help set up rides and transportation and where our members can go locally for things. Then we also have both nurse care coordinators and behavioral health care coordinators who can provide both telephonic and community-based outreach and care coordination. So we have our nurse care coordinators who can go out and meet people in the hospitals, can go to their homes to meet with them. We have other folks, our health resilience specialists that are embedded in some of our primary care clinics that work directly, potentially with your teams here. We have pharmacy support on every team. So we have a pharmacist dedicated to each of the teams that help do medication reviews when there is a hospital admission, and they work closely with our teams regularly. And we also put the provider network in here because we really want to make sure that when we are working with a member, that the providers know that we're working. And the providers, maybe not necessarily the physician, but somebody at that clinic who we can call and coordinate with back and forth to make sure that, one, we're not duplicating services, but also that information can be shared back and forth with that care team at the clinic and our care team here at CareOregon. So I worked as a care coordinator for several years at Family Care, and I think it took me probably a year and a half to really understand what care coordination was. It is kind of a confusing thing if you either have never experienced it or worked with a care coordinator. A lot of our care coordinators, including myself, had come from the provider world, and so switching that lens of, oh, I'm not actually providing care, or I'm not providing nursing, or I'm not doing therapy, to kind of looking at the whole person care and how can we make sure that everyone involved in this person's care are talking and have the right information. Care coordination has become sort of more prevalent within the CCO contract and within the ORs at the state level because of this sort of need from kind of the state and federal lens of, we have all of these great services and all of these great providers who could potentially be kind of duplicating care. And so how do we really make sure that the members are getting the right care that they need from the right places? How do we make sure that we are helping complement the services that are already provided in the community and make sure that information is easily attainable? There's a few OARs that specifically talk about what successful care coordination looks like. This is also in our CCO contract coming up in 2020 around successful coordination requires exchange of information, an easy exchange of information. I think we're all trying to figure out what that actually looks like and how, when we have a care plan, how do you as providers want to receive that care plan? Is it even helpful? We've been working with some of our clinics to say, is it best to be faxed in? Some say yes, some say please don't fax it to us. Others say put it in collective, we want to look at it in collective or pre-managed, but not everyone has access to that. And so it's really trying to figure out, okay, if that's successful care coordination, how do we actually do that with either the technology that we have or the platform, and how do we actually make it work and have the members know, or your patients know, what that care plan looks like, what the information is that we're all looking at. So in the OARs and in our contract, there are several requirements around care coordination. And there's sort of 6 kind of main themes that I've seen consistently across the years, and there are several draft OARs that talk really in depth about what care coordination is and what care coordination should be. And the themes are still pretty much the same. Really, it's about providing access to care coordination. So all members of the Oregon Health Plan have access to a care coordinator, have access to care coordination. Whether or not it's useful for them or needed is a different story, but everyone should have availability to call up us or their provider and get access to care coordination. Another main component is connecting people to services. So making sure that our members know, again, who their primary care provider is, what clinic they can go to, what specialty services they can access, and what that means. Providing transition planning and follow-up. So this is helping members through a hospital stay and helping to facilitate that transition back into the community or back into a different level of care. It talks a lot about following members or clients throughout levels of care and making sure that they're in the most independent and community-based setting that's appropriate for them. Once we enroll someone in care coordination, and even prior to that, we are assessing for what the coordination needs are for that member. Again, not every member needs care coordination, but for those who do, we want to assess what really are those needs. It might be a transportation issue that a member calls in about, and in working with them, we find out that we can be helpful in a lot of other ways as well. And then developing and implementing individualized care plans. So this is what I was talking about. We have to have a care plan on every member that we work with. And although it's a state and federal requirement, there's also a reason for that, right? We have to be able to show what are we doing, what are the needs of the member, how is that working with their treatment plan at their provider office? Are they complementing each other? Does everybody know what's on that care plan? And this is really where we're trying to figure out what is the best way to exchange that information, and we're not quite there yet, but we're getting there. And then the last thing is that both the OARs and the CCO contract, as well as federal regulations, really talk about priority populations that we need to look at. And a lot of these priority populations have really complex behavioral health diagnoses or behavioral health clinical presentations. A lot of pediatric populations are coming in next year or into the rules next year around making sure that youth in foster care have the supports and services they need, and youth who are in residential treatment or have maybe behavioral health issues that are that could be boiling up, that we want to be able to provide support to that youth and that family to say, how can we best support you through this maybe crisis? But the way we use our technology and our care coordination platform is really around this assessment and care planning. So we recently implemented a new care coordination platform within the last year, and it's had some ups and downs whenever you go to a different documentation system. It has its trials and tribulations, but I think we're getting closer to being at least more familiar with the platform and how to utilize the care plan and the assessment. And what we're finding is that, or what the purpose of this platform is saying that the care plan and the assessment really should drive what the care coordination looks like and who should provide it. So when I was talking about earlier the proactive case finding, so within our kind of regional care team structure, we have triage coordinators that look at the data and the member list to identify that rising risk group for our teams to proactively engage. And they might do sort of an initial needs assessment on what are the initial needs of that member based solely on the data that we have and the information that we have in our systems. And then we also have our healthcare coordinators who receive care coordination referrals all the time from, again, you all sitting out here, our community, our internal departments, maybe members themselves. They will also do sort of an initial kind of intake or needs assessment on what's the reason why they're coming in for care coordination. And then from there, a care plan is created. So we have an assessment built where, based on the information entered into that assessment, it kind of produces a care plan, or at least an initial care plan. From there, we try and look at, based on those needs, who is the best person on our team, because we have multiple roles on the team, to serve that member. And so this is kind of a really simplified way to look at it, but the first thing we look at is there a clinical component to this member's presentation or the coordination needs? If there's not, if it's DME related, if it's healthcare navigation, community resources, maybe it is a really complex member, but their provider has kind of those components covered, our healthcare coordinator may keep that case and provide telephonic care coordination for any amount of time needed. But if there is a clinical need, again, this is a very simplified way to look at it, but one of our clinical care coordinators may then take an initial stab at further assessing the needs of that person. So then the second question we ask is there a need for that member to be met out in the community? Can we provide telephonic support for this member and it be successful? Or do we really need to go to their home? Do we really need to meet them at a coffee shop because that's where they go? Do we really need to go to a park where they might hang out or potentially live? Do we need to meet them at their clinic because they're scared to go into their doctor's appointment and we can help maybe advocate for them? So if it doesn't seem like a face-to-face in the community need is needed and that a telephonic support might be available or might be successful, then we look at what's the primary driver of those needs. And if it's physical health, then one of our telephonic nurse care coordinators would take point on that case. And if it's behavioral health, one of our behavioral health coordinators would take that case. If there is a face-to-face need, we ask sort of that same question of what's the primary driver, and same thing. So if it's more medical or physical health related, our community-based or transitions nurses will go out into the community and meet that member. Or if it's behavioral health, maybe one of our health resilience specialists will take on that member. So again, this is a pretty simplified way to look at it, but we are trying to figure out how we can best utilize our internal resources to work with our members and work with you all who showed up here today. So if you guys do have care coordination referrals or want to access our teams, we do have a centralized referral process. We have a care coordination form on our website. It's kind of hard to find. Mid-December, it will be easier to find. But we provided the link. It's a fillable PDF on our website that you can either fill out, you can fax that in, you can also call us. Customer service, if you call customer service, they can connect you to the right regional care team. You all also might know who your regional care team is if you're a primary care clinic provider. Or you can email our healthcare coordinator team at ccreferral@careoregon.org and let us know how we can help. All right, that's all I got.
Thank you, Karissa.